I'm Jane Ashworth. I'm a consultant paediatric ophthalmologist at Manchester Royal Eye Hospital, and I have a bi-weekly paediatric uveitis clinic when we see about between 40 and 50 patients. And I also have a monthly clinic that I run with the paediatric rheumatologist in order to manage these patients together. And this presentation will hopefully explain to you why there is the need for that. So I'll just wait for the last few stragglers to come in and sit down. First of all, I'd just like to say why paediatric uveitis is so different to uveitis in adults. So as you may know, paediatric uveitis is usually asymptomatic, and for this reason, some children present already with complications when you first see them because nobody has been aware that the child has uveitis. They are at a high risk of complications because they don't have symptoms, and most children with uveitis need systemic immunosuppression. I know that's quite contentious, but I think that's quite true. Certainly that's what the Americans are, how they manage their patients. So whenever you see a child with uveitis, don't be tempted to just keep seeing them every few months, keep treating them with topical or oral steroids and not do anything about it, because that is not how these children need to be managed. Children with uveitis often, and much more often than adults, have a systemic disease, so you always need to investigate them for systemic disease. So these are the key points that I want to get across in this short talk. All children who are at risk of uveitis because of their medical condition need to be screened for uveitis, and particularly the group that we think of is those with juvenile idiopathic arthritis. I'll talk a little bit more in detail about that. All children with uveitis need to be referred to a pediatrician and ideally a pediatric rheumatologist to exclude systemic disease, even if it's unilateral uveitis. All children with uveitis need to be considered for a disease-modifying anti-rheumatic agent, and the most common one that we usually use is methotrexate. There are other options. So most children who have uveitis will need methotrexate. And you want to do that sooner rather than later, and you want to treat them in conjunction with a pediatric rheumatologist, or certainly a pediatrician who's very familiar with using these systemic immunosuppressions, because as a pediatric ophthalmologist you do not want to be taking on the responsibility for the side effects and the blood monitoring and all the issues that come around using chemotherapy such as methotrexate. So therefore you want to treat these patients ideally in a multidisciplinary clinic with access to your pediatric rheumatology colleagues and dedicated nurses. So in the UK we have a screening program for children with juvenile idiopathic arthritis and other rheumatological diseases, and the guidelines were actually published in 2006, which is a long time ago, but we still use those guidelines. And you need to be able to have a clear referral pathway, so a child who is diagnosed with juvenile idiopathic arthritis or suspected of having that by the pediatric rheumatologist or the pediatrician can quickly refer to your clinic to have or their local clinic to have their eyes screened for uveitis. And you need to engage with those services so that they will also be able to help you when you come to them with a child needing systemic immunosuppression. And you need to develop a very good relationship with those pediatric rheumatologists or pediatricians. And in order to be able to do this properly, you need to have a clinic with adequate capacity so patients don't have to wait. Ideally, a patient who is diagnosed with uveitis needs to be seen within 6 weeks or within 1 or 2 weeks if they're symptomatic. Who's been diagnosed with juvenile idiopathic arthritis rather, and who needs their eye screening. So all children with uveitis need to be referred to pediatric rheumatology to be investigated for systemic disease, and these are the kind of diseases that you need to investigate for, and even if they are asymptomatic, because I've had patients in whom the parents have insisted there is nothing wrong with their child, and actually on examination they have had a swollen joint or some evidence of some other systemic disease, so don't take the parents' word for it. And obviously infectious diseases are a prevalent cause of uveitis, TB and syphilis. Lyme disease, I put a query because we don't regularly test for that in the UK, but it may be more relevant in other parts of the world like America. And then there are the other conditions, the other autoimmune conditions, sarcoidosis, GPA, and other diseases that are associated. So my other key point is do not delay starting methotrexate, most children, obviously not absolutely all, but the majority of children will need methotrexate or another disease-modifying agent. So you need to refer them early to a tertiary centre with paediatric rheumatology. If you're going to use oral steroids, which you might need to if it's very severe disease, use a short course, no longer than 3 months, because if you use it for over 3 months, you're likely to give your child side effects such as this Cushingoid patient here. And if you have a child who has, for whatever reason, sometimes it's unavoidable, been on steroids for more than 3 months, you need to refer them to paediatric endocrinology for synacthing testing, because they will have adrenal suppression. Otherwise, you could make them very unwell. So my policy, and the policy, I know in America they also have this, is that if you have a child who's still on drops after 3 months or still has any disease activity with more than 1 or 2 drops after 3 months, you need to consider something systemic like methotrexate. If they've been on methotrexate for more than 3 months and they still have activity or requiring more than 2 drops, you need to think of something else. And in the UK, we have approval to use adalimumab as an anti-TNF agent, which is the next line treatment. And I look after a lot of patients who are on both methotrexate and adalimumab to control their uveitis. So the reason we do this is to avoid the use of too much topical steroid or oral steroid, so that we can reduce the side effects. And also we know that uveitis itself causes cataracts and glaucoma. A lot of children get a steroid response, and it's not unusual for that steroid response to then sort of turn into glaucoma. So we need to keep very close watch on that, and we need to follow up our patients closely. Patients using these medications can have lots of issues. They can get liver problems, they can get side effects. So we need to counsel the patients, support them properly, monitor with blood tests, and all this needs to be done in conjunction with the paediatric rheumatology in an MDT clinic. When we're looking after patients with uveitis, we also need to be aware that they can lose their vision for other reasons other than cataracts and glaucoma, and we need to be aware of the potential complications that can occur from the uveitis itself. So regularly monitoring these patients, checking their vision. This is a patient who had bilateral idiopathic uveitis on methotrexate, suddenly lost vision in one eye down to 1.5, and was found to have a subretinal neovascular membrane. So remember, these rarer things can occur in these children, and be aware of them and monitor them, and this child was treated with Avastin. The other thing is, as I said before, consider alternative diagnoses. Children with uveitis may well have an underlying systemic disorder. Particularly juvenile idiopathic arthritis is the common one, but then we can have some infective causes, and this is the child with chorioretinal scarring that turned out to have TB, and obviously they are treated with the anti-TB treatment and oral steroids. So in summary, children with pediatric uveitis all need to be referred to paediatric rheumatology to exclude systemic disease, because a significant proportion will have systemic disease. Ideally, they need to be treated in a specialist uveitis centre, or certainly by someone who has a lot of experience in paediatric uveitis, ideally in an MDT setting, or at least with access to easy collaboration with paediatric rheumatology. Avoid delays in assessing these children, whether that's for screening or for referral once they've had a diagnosis of uveitis. Avoid delays in starting the treatment. Start disease-modifying agents early so you can reduce the amount of steroid these children need to use. Usually the first-line agent is methotrexate. If methotrexate alone doesn't work, then escalate the treatment to add in an anti-TNF, and to be aware of the potential for complications, and diagnose and manage these promptly. Thank you.